Hello all, I'm Dr. Santoshi Nagaonkar, Director of Department of Urology, Urological Cancer Surgery and Robotic Surgery. The month of November each year has been observed as Men's Health Month. And there are various diseases which we try to look after, mainly related with men's health. And one of the most important diseases which we encounter nowadays is the prostate cancer. So we are going to run this series of conversations with various specialists who are involved in treating prostate cancer patients. And it's a teamwork. Only one person cannot, or one surgeon cannot treat prostate cancer. So today, we have our head of medical oncology and precision oncology, Dr. Sewanti Limaye, in conversation with her with regards to certain prostate cancer questions which are asked to us quite often. I welcome Dr. Sewanti.
Thank you.
Welcome, Sewanti.
Thank you so much.
Thank you for being here. So we are going to have a rapid fire kind of discussion. And my first question to Dr. Sewanti is about the genetic link-up of prostate cancer. What is the percentage of gene-linked prostate cancer, and what all things or what all measures we take to identify such individuals?
So thank you for having me, Santoshi. When we look at a patient who has multiple male family members with prostate cancer running through several generations sometimes, or father, uncle, another uncle, that's a red flag. You really need to understand whether this runs in the family for two reasons. One, risk stratifications to understand how much risk that patient have. And secondly, for also understanding what therapy could be proposed for that patient. Can that be done something differently? Can there be a role of a targeted therapy for that patient? For that, we need to ask a question whether the patient has a germline mutation, which is inherited, which runs in families. So there are two types of pathways that drive cancer and genetic tests that we need to do. Any cancer that runs in family needs to have a hereditary testing. The person needs to have a hereditary testing that's called germline. And the genetic mutation that may be driving the cancer in the tumor is called somatic. So here I'm saying we should do the germline testing to understand if that gene is being carried, and that would put the person at risk for prostate cancer.
Excellent. So one basic question which comes to us and as audience as well, what do you mean by the targeted therapy? Just as a basic thing, because it's a very commonly used terminology. What do you mean by that?
So actually, cancer cells have various targets on their surface or inside the cell. When we use targeted radiation, it's physically targeted to that particular site. But when we use a targeted therapy that is taken orally or that is given intravenous, it goes in and homes into the cancer cell area. It actually then attaches to the receptor on the surface of the cancer cell, or sometimes it can even get internalized. A targeted therapy can get internalized and act on the inside portion of the receptor that is there on the surface of the cell. So essentially, it is targeting a particular receptor, a particular pathway on the surface of the cancer cell. That's a targeted therapy. It also works differently. It doesn't lead to major cell kill. It cuts off the pathway of multiplication. So the cell death happens slowly. It usually doesn't happen very dramatically like chemotherapy does.
Correct. So in the nutshell, that is the importance of doing the genetic testing, because as we know, any man who is born in this world carries about 13% risk of developing prostate cancer. And any of the first degree relative gets afflicted with prostate cancer, the risk doubles up. It goes up to 30%. If two members are afflicted, it becomes 50%. And it goes up to 90% if three family members, the main family members, they're affected with prostate cancer. That's why nowadays we are trying to identify those individuals who carry this risk of developing familial type of prostate cancer. Thank you, Sewanti. Now the next question is going to be probably which is very close to your heart, is what is the importance of chemotherapy in prostate cancer? About 15-20 years back, there was no role of chemotherapy in prostate cancer, but now it is an emerging therapy. So can you just tell us where can we place this chemotherapy in prostate cancer?
Sure. So earlier, chemotherapy was only utilized in the treatment of advanced prostate cancer patients once they had progressed or failed hormonal therapy, and that would be somewhere around 3 to 4 to 5 years after they were initially diagnosed with metastatic advanced prostate cancer that had spread to different organs, bone, everywhere. Slowly, the research and the field has developed in a way that now, if there is a robust, youngish male who has prostate cancer that has metastasized or spread, we actually offer triple therapy where dual hormonal blockade plus chemotherapy is offered right up front when the patient presents, especially if they are presenting with larger disease volume. So if they have multiple lymph nodes involved, if they have different organs involved, we may actually then recommend triple therapy, because when we combine chemotherapy to dual hormone treatment right up front, as soon as the patient is diagnosed, you get the best results and longest outcomes. So survival is really prolonged when we give triple therapy. So chemotherapy is really being utilized in different ways now. So of course, for those patients who have already started on hormone, did not get chemotherapy upfront, they are still candidates for getting chemotherapy after the hormone has stopped working. And then we talked about targeted therapy. So there are a specific class of drugs called PARP inhibitors that are being utilized for systemically, are being utilized for BRCA positive or HRD positive prostate cancers that are metastatic. So they're being given in maintenance setting. There's a different variant of prostate cancer called neuroendocrine type of prostate cancer. There, very different type of chemotherapy combination is utilized. You prove it on a biopsy. Once you have proven that this is neuroendocrine variant, different kind of chemotherapy is utilized. So the field is evolving. Many new therapies and new combinations are coming through. New hormones are coming through. New targeted therapy. Once in a while, when we do comprehensive genomic analysis, we may find a very rare target for which there would be a tumor agnostic application of targeted therapy. So a lot of options now, even for advanced metastatic prostate cancer, and one has to really get to an aware center to get the right answer.
Excellent. Thank you. So in the nutshell, the take-home message is the future is promising. When I was doing my residency, we didn't have too many options to treat prostate cancer. So orchidectomy and prostate removal, they were the only options, and some patients used to get qualified for radiotherapy. But now the field has evolved. We have got a lot many new therapies are coming out. Chemotherapy, immunotherapy has evolved. So no more we are considering prostate cancer as a death sentence. We have a lot many options. And I really thank Dr. Sewanti for being here. And we'll continue our series with different specialists talking about prostate cancer. Thank you.
Thank you.